Morning, Black Doctor. We are here live from Martha's Vineyard for Health Policy Day. Yep.
Hey everyone, we are live on blackdoctor.org. We are here for Touch Talks Wellness 2025, our Health Policy Matters Day. And so I'm going to actually hand it over to my husband so we can get started with some with the panel.
This is my official capacity today. Not professionally affiliated, for those of you who know me in a professional capacity. All views shared today are Haley's own. And in that context, we'll have a great conversation about health policy. So just so you know, I'm private equity, I'm an investor, and we invest in life sciences broadly, as well as healthcare. So I'll go ahead and sit down. And I'll ask the ladies when I announce them to come up and take their seats as well, and they'll give you a little brief introduction about themselves when they're all seated. So Ms. Profil, maybe a little round of applause with the state. Anywhere you choose. And then Mr. Keisha Everett. Good morning, good morning, good morning. As well, Miss Danielle Scott. And for the moment, last but not least, Miss Lavanya Harding-Wright. And so obviously, as you can see, we're waiting for awesome. We're waiting for additional panelists, Miss Tammy Boyd, as well as Dr. Yolanda Lawson. In the meantime, what I'd like to do is ask these ladies to introduce themselves, as well as to introduce, along with that introduction, to provide a little context for why you're here and what your professional and personal experiences is that's contributing to your perspective.
I'll start. Hi, everyone. I'm Pearl Phillips. I'm CEO and founder of SITE, the community initiative for trial equity. I design equity-based clinical trials. I am a breast cancer survivor. I'm one of Brittany's blessings. Thank you for having me here. I was diagnosed with stage 0 breast cancer, DCIS, in 2022. So it's been about 3 years for me now. But not only that, I am a clinical trial strategist. I've designed clinical trials. I'm ex-IQVIA, ex-ICON for a contract research organization.
Oh, you gotta know. those for you that don't know, and she won't say this, but those are the 2 largest clinical trials companies in the world. So I'll go around and talk about it.
Thank you for that. Yes, so I've been around a little bit the clinical trial space, designing clinical trials for large pharma organizations, and also incorporating diversity strategies into those plans. I'm also a public health nurse. I spent about 15 years in public research. A lot of us nurses out there designing clinical trials. And yeah, so I also have a master's in health policy and research.
Not all y'all got masters. I mean, give it up.
So, my focus is, my passion is, of course, clinical trial strategy, but also health policy. And, we need to make sure that we are designing clinical trial strategy that is inclusive and that helps to dispel health disparities and make sure that, we are designing medications that are designed for people of color. So that's a passion of mine, and that's why I'm here. And I think that, also we can't just talk about it, we have to be about it, and we have to have the legislation to back the policies that we need to make sure that that inclusivity happens.
Thank you. Appreciate that. Next.
Hi, my name is Dr. Takesha Dewan Everett. I am currently serving as the Executive Vice President at Trust for America's Health. Disclaimer, all of my opinions today are my own and do not represent TIFA. In my spare time, I'm also a consultant who does policy and strategy work with my own firm. my why and how I got here, it's a really simple but yet complex story. I am a former Medicaid recipient, so I grew up for most of my life on Medicaid, but in addition to that, I never met my grandparents. Except, most of us have 4 grandparents. I met one of those 4, and mainly because my parents have all died from preventable diseases that could have been taken care of if we had proper healthcare and a healthcare system that actually worked and functioned for everybody. So as a young person, I realized something was inequitable and wrong in our society, and I wanted to fix it. So I realized that policy is the driver of all the ills and wills that we see in our country. We'll talk a little bit more about that. More recently, I will say my why of being here, and particularly being on this panel that Ricky's put together, is because my aunt just successfully battled her first battle with breast cancer. And 1, she found it herself. 2, she advocated for herself. 3, if it weren't for my knowledge and my connections, we wouldn't have made it through what we did, because I served on like every FaceTime with the doctors, asking all of the questions. She gave her healthcare over to me and said, help me. And so we're here celebrating her 81st birthday because she wanted to come to her happy place and really enjoy the birthday. Happy birthday, Auntie. I'm not gonna call her out. She's here, but I'm not gonna call her out.
Hi, my name is Danielle Scott. I am a former executive from the DHS Office for Civil Rights and Civil Liberties. So I have a background in equity and in justice and a true passion for it. But today I'm here as an advocate. I have been touched by breast cancer in many ways. It runs strongly throughout my family. In 1995, I lost my aunt at the age of 32 from breast cancer. In 2020, I lost my mom. She was diagnosed, and then 2 days later, she was gone. And then in 2023, I lost a paternal cousin, first cousin, from breast cancer as well. So after losing my mom, I took my own personal journey and made certain that, this was also going to be my fate. And I pushed my doctors to do a double preventative mastectomy. It was a very, very hard fight. But I was able to achieve it, and I was able to achieve it with my insurance covering it, which was a tremendous blessing. So I'm sitting here now in the capacity of being an advocate, sharing my story, addressing any questions that anyone else may have in regards to that process, because I know there are not a lot of us, that look like us and that are in, this world that have kind of gone through that preventative double mastectomy process. And I know that education is power. So I am here as a wealth of knowledge and also in the advocacy capacity. Good morning. My name is LaVanya Hardin Wright. And good morning. My name is LaVanya Hardin Wright, and I am the head of Giving and Social Impact for Genentech. And my role at Genentech is to identify strategic opportunities to make philanthropic investments. I am passionate about.
You say that role again?
Identifying strategic opportunities to make philanthropic investments in our community. And this is one of I recognize that there's disparities in care, and Black and Brown folks are, we suffer the most when when the world catches a cold, we catch the flu. And so I look for organizations to work with to either help develop workforce, recognizing that culturally empathetic, competent care is important for us. And I also look for opportunities like with Ricky with Touch to make investments to support health screenings for women, because that's, we need access. If we don't have access to screenings, or if we don't know that we have an illness, we can't do anything about it. And so preventative care is very important. And the first phase is screening and identifying the illness. And so that's my role at Genentech. And that's what I'm passionate about. How do I support my community?
Thank you for supporting Touch. Thank you. Thank you.
Good morning. I am Tammy Boyd. My background, former Capitol Hill staffer, worked for Congressman John Lewis as his LD, overseeing his health policy. Also, Benny Thompson And then have various. And have held various roles from incorporated to large nonprofit to be a nonprofit, currently consulting with health insurance company now. And then in terms of these questions about the why, originally from Mississippi, as you know, disproportionately African Americans are pretty much impacted by every and so that was really the catalyst for me going to into healthcare, have an MPH, and also a lawyer by training.
No, thank you everybody for all of those, for the work you do, but for sharing the work that you do with us, and for directly touching and impacting, you know, the people in this tent, in this immediacy, the people live streaming, but certainly around the world. It strikes me that all of you, whether it's Acuity and Icon for your current state, or it's with Genentech in your role, or it's with congressmen, or it's with the community, all of you have a wide diaspora of individuals that you've come in contact with, and without you the world would be a worse place. So one more time, please. So with the introductions kind of given, I want to make sure that we focus on the programming. The first question that I want to in your professional, personal capacity to kind of provide a perspective on is, how did we get to where we are today? Where are we today, and how did we get here? And feel free to answer that question historically, institutionally, again, professionally, personally. What are the markers that have created the environment that persists, and help localize that for the audience out there, please? Let's go in reverse order, or actually start here.
Okay, I'll start. So, so I said I'm Dr. Takesha Dewan. I have my PhD in sociology, and it's an emphasis in race policy, race, gender, and social justice. So the lens I
PhD in what again?
sociology, race, gender, and social justice is the focus. And I
Thank you,
choose to look
Doctor.
at public policy. But the reason I say that is because the way I address and look at things when I talk about this question is, you can't talk about how we got here without understanding the historical nature of the United States, right? We were founded on a principle that certain individuals will be unequal, and the history of our policy follows that. So if we just take a second and think about our healthcare system, we started with a healthcare system that had a healthcare system for the owners and a slave healthcare system for the enslaved. And that gave you an unequal, inequitable healthcare system from the beginning. So we had great hospitals, and doctors used to come to your house and all of these things if you could afford it and you were the owner. But for the enslaved, you had a secondary healthcare system that either basically only existed to keep you healthy in order for your labor to produce for the owners. So as we get out of that and we move forward, we no longer have an enslaved system. We have now said, but wait a minute, y'all might be free, but we don't want y'all in our hospitals. So we'll develop clinics. And we'll give those clinics less funds, less resources, and we'll use whoever we can to get there to do that work for you. And right there, that has been our system ever since. We created a safety net that has never been fully funded, never been fully supported, never been fully equal to our hospitals and healthcare systems that are in the suburbs and made for other folks who quote unquote can afford it. So we just have this bifurcated system where we haven't been giving the funds and things that are necessary for everybody to experience health. And yet we expect a different outcome. We expect that people who do not fully have funding and support to get the things they need to actually be able to somehow become and remain healthy. We expect for people who've never had trust in the system that you were there for them to really trust you now when you want them to be in your clinical trial. I'm gonna stop on that because my sister gonna talk about that. But it's just the whole point of, we've never had an equal system. We've never started an equal system, and it's all driven by our policy choices and decisions. I think I'm supposed to say later how we get out of it, but not right now. So I'll pause right there.
Don't give us the whole dissertation. Gotta catch up. We gotta catch up. Can you guys hear me okay? By the way, it's cutting in. Can you hear me when I use my voice?
No.
Okay, so I like the sound of my own voice, so. Thank you. Appreciate that. Anybody else want to take that? Because I know there are a couple of different perspectives.
I could just take it from the perspective and from the policy side, and also two of my colleagues, Lakeithia is here from Eli Lilly, and then Lisa Sherrod from AT&T. But but they can attest to this. I mean, when we first started on the Hill, just we're now talking about some of the problems that persist within the Black community in terms of health disparities. But when you walk into the rooms, when you're actually writing the legislation and the laws and navigating, literally would be in each of the conversations, would be the only person there. And so it's getting better now that we have a larger Black caucus. I think when we started, maybe 30 members, and now we're up to 62 members. It's getting better, but just making sure that we're at the table and we understand how to navigate the process. And also, organizations like Ricky, having the community also push in to really elevate is really key.
So you're talking about the solution. We're gonna get there, but I appreciate that. Thank you because what I heard you say, so I'm gonna have time to interject because as I said, I like to hear the sound of my own voice, but also, as an investor in this space, we look for a few things. And two of the things that I heard were funding and policy, regulatory framework. Does anybody want to speak to a couple of other things as we throw out the thesis points?
Yes, I would call out their treatment deserts. So there are some communities where there isn't a clinic or a hospital. You may have to travel over an hour. You may not even have funds to for transportation. So that's an issue. I would also say that if you have Medicaid, in some states, Medicaid was not expanded. And so there may not even be preventative care available based on your insurance plan. That's also an issue. So when you think about access, you think about resources, they're limited in our communities.
So what I'm hearing now, so we've heard funding, we heard policy/regulation. What I'm hearing now is infrastructure, right? The plumbing, when you go out a block, a mile, 10-mile radius, and there's no infrastructure to remain or become healthy. Does anybody else want to take, maybe from a personal perspective, what are potentially from conversations earlier, I've heard you say a couple of things about your personal experience, your family history that kind of has led us here. So maybe do you want to talk about?
I would say us not sharing our family history with one another. I didn't know that my father had diabetes until he ended up in the hospital with a broken hip. And that's when he finally told me or shared that information with me. So I think us culturally just not sharing our information and understanding that it's equipping the next generation to do more preventative maintenance and to make certain that we're not getting into these spaces.
Hey, Jordan,
Yes.
I know not about the
Come.
I think that also, what we teach is health and literacy. And I know that, we hate that word because it makes it sound like our fault. But, health illiteracy, we see it every day, and I hate that word because it makes it seem like it's our fault. But we don't know what we don't know until we're on fire. People don't know they have breast cancer they're sick until they have breast cancer. The only time they've been in the hospital is when they had a baby. And so I think our families aren't talking about it, to your point, but we just don't know about health. We don't talk about it and we don't know what we're into. Even more educated. I have a lot of degrees and I didn't know anything about breast cancer until I got it. So just add that to your list. Sorry, I'll shut up now, Jordan.
That's it. That's incredibly important because it adds to our thesis point, right? Again, work with me here. What we're going to do today is we're going to build an investment memo real quick. So in that memo, we have the problems we're trying to solve for. Funding, sharing your family experience / access to knowledge, and that's from a personal level. Ricky's talking about it from a community level, but it's the same kind of access to increase of education. On the end, we have the regulatory framework, And in the middle, we have the infrastructure with Ms. Lavanya. So with those points kind of defining how we got to here, and let us now define where here is potentially. And then from there, we'll go into what the solution is to get where we're going. And that's what we'll all invest in at the end of this. Make sense?
So thank you. So from a clinical research perspective, right, this is important, just to kind of frame it off the top. I think Ricky and I, we both do a lot of work talking about clinical trials. And I don't think people really understand the importance and the importance it has and it plays in the legacy of health for us and what we leave to our children and our descendants. But if research is not done for us and we don't understand how medications work on our bodies, then it can't possibly work for us and promote our health. And it actually furthers health disparities. So what's happening is the history of in clinical research and legislation and regulatory frameworks is right now we have something called the FDORA Act, right? And that's the FDA, their Food and Drug Administration Omnibus Reform Act. And this mandates that we now put diversity plans into clinical trials, right? So that legislation was passed in 2022. So finally, there was supposed to be, guidance on how to actually implement these diversity plans. And it's good, it's important because we need to have input from our communities on actually how to get people into clinical trials, how to recruit them, how to retain them, and how to get community engagement. But what's happened most recently with some DEI rollbacks back in January, that guidance to pharmaceutical companies and research organizations who are conducting these clinical trials don't actually have the operationalization that they need to understand how to do a diversity plan.
So hold on, let's stop right there. That guidance. So what you're speaking to right now is for some amount of years recently, call it 10, 15 years, there's been a wholesale shift, several wholesale shifts in how we access healthcare, and infrastructurally with the FDORA Act and other.
And even prior to that, I think the first legislation we ever had for diversity and inclusion was in 1993 through the NIH Diversity Act. And that was more, and this is what we need less of, it was more of a performative act that was passed that really didn't have any teeth and really no way to enforce making sure that not just people of color got into clinical trials, but that white women got into clinical trials too, because historically clinical trials have only been tested, drugs have only been tested on white men's bodies.
So let's pause right there again. So for the audience out there and in here, what I'm hearing is that there have been several iterations of policy that have maybe oscillated from administration to administration that haven't worked to effectively close the gaps in care or the available resources or the available funding, the available infrastructure, the ineffective policies, and no addressal to the community level or the population level health. Is that kind of what I'm hearing?
Absolutely. And on top of that, so there have been some progress made in the past few years. So right now there's we have to talk about the progress, not just any sabotage that may be going on, but the progress. So there, most recently, from the time that first act was passed back in 1993, there's recently been legislation proposed by the NIH to expand on that and actually, have folks who are doing research actually report on the diversity of the trials and what that includes. Did you, Ricky? Can't contain yourself.
So that's all well and good, but the legislation is for phase 3 trials.
That's right.
So there's
And
three,
biologics.
three phases of clinical trial development. Phase 1 is for safety, phase 2 is for safety and efficacy. Phase 3, when they're comparing it to standard of care. If the Black people are in phase 1, then men. Sorry.
So, again. No, stay, please. Actually, there's a seat open next to me, by the way. But, so what we're hearing, right? Just to localize the conversation, because it's getting a little technical and I want to make sure that I'm keeping up. And you. But what we're hearing is that there's been a number of opportunities, potentially ineffectively, to try to admit folks that look like yourselves, that look like me, that look like us as a community, into increased trials or availability of trials or availability of what I'll call care, ubiquitously. And that opportunity, whether we've gone through iterations to have effective policy or have increased funding, has not led to a bend in the cost curve, has not led to a closure in gaps, has not led to improved outcomes for our population. Would anybody disagree with that? Perfect.
All of that is true, but I also think that the way our system is set up, I'm gonna try to be as nice about this. I'm gonna let Tammy be more diplomatic about it. The way our system is set up is that we have an episodic Congress. So every 2 years, you're flowing over and turning over. And so basically, once a person runs and wins, they're running for office again. So what people are looking for in their ability to maintain their position is what's the quick hit, the quick win. And we're not really looking at the longevity of policy. Then you put on top of that, your president changes every 4 years, the administration changes every 4 years. And most people, if you're politically appointed, all of those political appointees change every 4 years. So I'm saying that to say we have a structure where even when we look at 1993 and we have this bill happening in the NIH, people are looking for quick wins on things that take 10, 20, 30-year horizons. So we're not giving ourselves time to actually see what our policy changes can actually do. Now, when you say, how do we get here today and what we're going through, we're now looking at it, well, wait a minute, all that stuff looked like it was working. We're taking it off. We're pulling it off because we think it's unfair. We think it's unequal. We're not the we. Y'all know who the we is. And so we're in a situation where what my sister's talking about here, we can't even, we started to get somewhere, but now we're seeing a retreatment from where we're going.
It's been 30 years
30
since
years.
that time to provide any sort of act, because actually the Fedora Act is the only legislation that we have that's demanding diversity in clinical trials. Where these acts are still out there, they've been out there for a couple of years, they're not actually in law yet, so.
This was just an interesting point that I think was brought up because, again, I'm going to relate it back to this scenario where we're going to identify an issue, understand the circumstance, provide a solution, and then invest in it, right? I think what Miss Takesha just identified was the table stakes. So all of these things, the funding, the infrastructure, the policy, and largely the current state, those things can change and can fluctuate, but the table stakes are the system that we're involved in, that we all participate in. I use we specifically because although that we may disagree, we all on this boat to whoever knows where together. In that system, the table stakes are that the system changes and is volatile within an infrastructure. And so now, unless there's another point.
Can I please
Please.
add that
Yes, you may.
most folks aren't even offered the opportunity to participate in a clinical trial. Their physicians don't even offer that to them. So they don't even know about it. And I know we're going to get to solutioning, but I think that's also something that we need to address. How do we educate and inform?
Sure. And so right before we get there, just to make sure that we're all on the same boat, you've got these 4 pillars of the problem. And then you have the environment in which we live, which politically has gotten even more contentious and volatile. And so I will ask you now, panel, with funding decreasing, with the recent bill that was passed that'll limit the amount of federal funding for government programs and push more responsibilities to the states, with the uninsured population anticipated to increase, particularly for Black and brown communities and low income communities, with outcomes by way of premature deaths, by way of chronic conditions, exacerbating and becoming worse for those populations that will now be uninsured and underfunded. What the hell can we do about it? What is the solution that we can all take from this conversation as we think about investing in our futures and the health and wellness of our communities?
And I just want to
I'm gonna be taking notes, by the way.
just before we go to the solutions, I also want to add to the landscape is the big beautiful bill, as we call it OBA, HR1, that was recently passed by this administration. And we're talking about cuts to Medicaid eligibility. We're also talking about ACA, the tax credit. So you have a lot that's at stake that people don't even know about. And some of those provisions do not even happen until after the next election. So I'm just kind of putting into the landscape. It's true. We already had a disproportionate impact to minority communities, but on top of that, now we have things, we're almost pulling back even the progress that we've made.
So tell me, what can we do? I might not leave your hand until I get a solution on you. Because here's what I'll ask you as the person who actually does. As the person who coordinates and whose experience professionally is to coordinate policy and to wrangle cats, as it were, what is the solution from a regulatory perspective, or rather from a representative perspective, that we can deploy as a voting bloc or as an individual with access to whatever resources are available to us?
Yeah, well, and I'll pick up what I was, saying in the first question, and also want to recognize Tawana as well. But one key part is really developing, there's Congress and the groups there are also staffers that remain and, some of the members continue to come back. But these groups are becoming increasingly important of cultivating community engagement groups and to really weigh in with Congress. At the end of the day, they're very interested in, what's happening to the constituents in their district. So that is, all politics is local. And so really understanding how to really elevate and the advocacy piece, even for the community organization groups, and even forming coalitions. Like, this is why I think this group is so important. And particularly within the minority, the African American community. There are a lot of groups, but there are really not a lot of groups that really know how to weigh in to actually change the policy perspective. And I know Yolanda, since you just get, for the National Medical Association, that's one of the things too as well, is really doing the advocacy, but also getting the doctors to weigh in. So
Love that. So let's introduce yourself, doctor, esteemed doctor.
Sure. I think this is on. Let me switch with you. Good. I don't know what time of day it is. Let's see. Is it morning? Okay. Good morning, everyone. So y'all know I'm putting out fires this morning. So I'm showing up, but I'm here and I'm present. So good to see you all. I'm Dr. Yolanda Lawson. I am an OBGYN by background and specialty. I am a past president of the National Medical Association. If you're not familiar, the National Medical Association is the largest and oldest organization of African American physicians in this country. We were formed in 1895. And we're the only ones that have been fighting for equity since 1895. Can I get an amen? And so, yes, I have worked with many on this stage and really happy. I really just want to commend Touch and Ricky for pulling this together. You got pharma, you got policy, you got clinical, and all of these perspectives, I'll say, matter. I got a lot of jobs, but I'll just stop there.
Thank you. So, Doc, you just mentioned something very important and I'm just gonna give you some catch up here. So what we've been doing is we've been building a little investment memo. So you know, my background is in finance and I think about things sequentially. And so what we've done is we've identified potentially through their perspectives, the esteemed panel's perspective on how we got it. Was through, you know, disproportionate and inequitable funding, infrastructure, regulation, and the access to knowledge, both on a family level and a community level, not knowing you need to know. We also then spoke about the current state and what the current state looks like, somewhat from a corporate perspective, somewhat from a regulatory perspective in terms of how we're operating today. And what we've agreed upon is that there is a solution to the table stakes of inequity in terms of those areas that we've identified. And we're now trying to tap into what are the individual solutions are provided from the perspectives of this esteemed panel. And so as they demonstrate, you know, their perspectives, I would encourage you to maybe think along the lines of what is it that you do in your capacity, either personally and professionally, that we can throw into the investment so that at the end of here, we can all leave here with something to put our own money behind or something to commit ourselves to grow from. Okay. And so our first, why don't you just give us a recap very quickly? Because you mentioned a couple of things in there, but specifically what I heard was being more of a community block and executing that through potentially your support of community-based organizations or through your support of different representatives in office. Just speak a little bit to that and then we'll listen about it.
Yeah, I would say, well, the 2 points, yes, definitely continue to build and invest in community-based organizations such as Touch. And then 2, also investing in, you know, increasing the number of African Americans that are going on Capitol Hill. So making sure that we are at the table, we're actually learning how to sort of navigate the process in order to make sure all these solutions that we're talking about that is actually included in legislation and law. We'll be up to you.
What I would offer from a philanthropic perspective, making investments in the community. I think that a lot of people really don't understand what the big beautiful bill will mean to them. I think that's what you were talking about, Tammy. And so part of the investments that we're making this year are in community health workers to help educate on what this means and what potential patients or members can do to mitigate what the big beautiful bill will do when we think about Medicaid and the changes to Medicaid.
No, I was just gonna say, just from an advocacy perspective, you know, my mother always taught me about the power of the pen. So not just writing your representatives, the individuals that are representing you locally, but also writing some of these corporations. There's a level of responsibility and an angle that we can push there to get some of this medical assistance or medical care covered through funding that they already have in reserve. So I know a lot of folks that have written these organizations and have been able to access certain treatments free of cost. So just educating ourselves there and just the power of the pen.
Just want y'all to know the panel's so hot, we set up the fire alarm.
You're gonna hear a common theme here. I believe you need to find your people. So when you leave this island, and if you're listening online, when you leave this conversation, you need to find your people. Be associated with somebody like Touch, some organization locally that's helping to break down this policy information as it's coming in. Too many people are listening to the news, and the news is giving you sound bites. It's not, I'm not saying it's inaccurate, but it's giving you sound bites. Sound bites doesn't give you education. You need to fundamentally understand the policies that are being passed, how it impacts you, your mama, your auntie, your cousins, and advocate for it. Support your members of Congress. And I don't mean support them financially. I mean support them by telling them what you believe, what you hear, how you want things to shift. Because if you're not at the table, you are what? On the menu, on the table, on the menu, and they're coming for you. And I think it's really, really important to understand. The other piece that I want to say that a lot of people aren't talking about moment, it's a minute, it's not a movement, it's a moment. There are going to be some fundamental infrastructure changes to our health and our system of democracy that didn't exist before. You are seeing right before your eyes a moment where we're going to have more enumerated powers than we used to in our president's hands than we used to. Regardless of what happens in an election, it's going to be more enumerated powers than we historically have. And you have to understand that before now, we did not have as powerful, excuse me, I'm not going to say that because I'm speaking it like it happened. Before what we're going through right now, we don't have as powerful a president as people think we have. So educate yourself on how the system works so that you understand the levers you have as voters and power to shift it. So find your people, understand the policy, make the change.
I'm gonna expand on that a little bit more. I think we need to make sure that we understand that we know who the community is, right? And the community of population, I guess according to legislation and how it relates to how people receive healthcare through legislation is Medicare and Medicaid, right? And the people who are probably most disproportionately affected by health policy are people who receive Medicaid. They're the people who are most likely unable to have PTO, a time off to participate or go to their doctor's visits or participate in clinical trials, receive healthcare, childcare, all of these things. I think it's important to target these populations and make sure that they know that their rights within health policy. And I think that a lot of people would be surprised, and I'll speak to my own area, clinical trials, they'll be surprised that there is actually funding for participation in clinical trials through Medicaid and Medicare, but it's not widespread. Even providers are not aware that this is available to their patients and participants. So I think that's part of the education that we need to first have so that people understand with things like the Big Beautiful Bill, what will actually be taken away from them that maybe they've never even utilized, or things that they are utilizing, they're not going to soon be able to have. So we need to motivate people to understand and contact their legislators and help push for policy, because the people up on the stage right now, we can talk all we want to, and until we're blue in the face. But at the end of the day, we need the support of the people, and we need people to understand what's at stake for them.
So I agree. And so I'm going to just kind of summarize this, from a clinical perspective. You talked about the policy and the advocacy piece, and extremely, extremely important. So, I'm faced with the patient in the exam room often. And I love that everyone here is saying, because I've been highly concerned that people keep hearing about this bill and fragments of the bill, but the people don't know how to put all this together. And you're exactly right. They certainly don't know how it applies to them. You think about something as simple as Medicare drug pricing, fixing. People are like, well, I'm not on Medicare. That don't matter. I'm 40 years old. But it does. I mean, even for me, the reimbursement I get from taking care of you set by the Medicare rate, right? The drugs that we need to give you for cancer, that's going to be impacted, right, by this Medicare price fixing. Multiple people talk about the clinical trials piece. Yes, there's frameworks for commercial insurance to Medicaid to go, right? There's frameworks in there, you're right. Providers in the community may not understand all of that unless it's happened to you before. Biggest issue for us from a clinical perspective, right? Screening. I'm getting that question everywhere I go because of these new rules, right? You just heard the United States Preventive Task Force Services didn't even get to meet. They set the guidelines when you can go get a mammogram. 30-year-olds come in, I want a mammogram. Well, you can't really get a mammogram. That's education. When should you get a mammogram based on your individual needs? And so we're faced with answering all these types of questions. How do we get people to even know about trials that they're eligible for? Where do you go to get that information?
That's what I think I'll ask you. So from a solution perspective, from a clinical perspective, take me through what these folks can do, because I heard you say a couple of things. One of them I heard you say, or one of them I heard you allude to, was the relationship between patient and provider.
Yes.
And talk to me potentially, if that's where you want to go. Have me mansplain to you. You talk to me about what that relationship needs to look like in order for these people and us and our loved ones to participate effectively in this new normal.
I'm not even gonna call it a new normal. It's not a new normal. We have been having disparities and gaps in care. That's not new, right? We do need to do a better job of making sure, I mean, I'm asked this all the time, people have insurance and still don't go to the doctor. Right? You didn't go?
No, not before I got married.
Oh, I'm
I
sorry.
got married a couple of years ago. Got married a couple of years ago. So it's like, I made sense. I made sense. Don't look at me like that. Oh my God.
But
That's the point.
no, I get you. Women come into my office asking me, how do they get their partners just to go and get screened?
Women want some things. That's how you.
Right, but that's even before you get cancer. I tell you, I had a lady who's a bus driver, a school bus driver, driving your kids to school. And when she comes to my office, cancer is growing through the breast. Like you can just look and it's draining and you can just see it. So I just scraped a little bit of it off just to see what it was. She was going to work every day driving that school bus. We get her scanned, she's got mets to the brain. Right? But that means at any point she could have a seizure, anything could happen. But she's like, Dr. Lawson, I gotta go to work. And you know, this woman told me I worry too much. And so when you talk about, I'm gonna call it denial. And we talk a lot about what we think our people don't have, even when our people do have, right? The denial and the reluctance and the fear. And so I think everybody, it doesn't matter who you are. I work in a community-based organization, 60% of our population is uninsured, right? But they know they can come in there and we're gonna take care of them regardless. Doesn't matter if you don't have insurance. And so how do we make sure that, especially in light of what's happening now, no matter where you are, that those places are identified, lifted up in our communities, even if they're just helping people navigate to care.
So there it is. And that's what's so beautiful about this panel is we talked a little bit about the framework of the conversation, but I think what you're hearing is the solution is arriving at the same place. What I'm hearing, and I'm gonna pass the mic around to a couple of you folks, so get your notes ready, because I want to know what you've heard. But what I'm hearing is that we need to be more active participants in this system from a knowledge perspective, and we need to seek out whatever resources are available, while also understanding that resources are hard to find and hard to come by. And when we do come across them, such as touch, we need to be active in propagating them throughout the community and lifting them up to the representative level where they can potentially be institutionalized in policy frameworks that can support current policy frameworks that have been trying to be supported for forever. This is nothing new that we're doing, but we need to take a more active approach at the personal level, the provider level, and then the community-based organization level, because those are the resources that we have to fall back on. Is that a fair synopsis of what we've been? Somebody like to season that up a little bit?
Just the industry piece, whether it's pharma, I think systems, we all see our hospitals are now systems, right? It's no more of that little community hospital. They're big systems. And I call that the task. I think they have a role too, because they're delivering, right? They're delivering resources to the community. They're the ones, when you look at your community needs assessments, they are supposed to abide by that. They get to choose what they want to direct their resources to. But that's calling people to task, but understanding those structures and there's things happening around you. How do you engage and how do you have voice to that?
I think we talked about that a little bit also. Making investments in the community. What we also do is lobby. We go on the Hill. We have conversations with elected officials to talk about we seek to understand what are the priorities for their communities. So to your point, Dr. Lawson, sharing with your electeds what your needs are. And then we bring that information back, and that's how I put my strategy together on how we're supporting the community to make those investments based on what we're hearing from those elected officials. But we also do listening tours within the community also to do some landscaping to understand in that particular area, what are the disparities and where can we play space?
I'll just say the two things I haven't heard us say as I listened to that recap was, one, get your children, grandchildren, children's children, all of those folks interested in being healthcare providers. We need to focus deeply on having concordant care from folks that look like us, who understand us.
Concordant, hold up.
That's what I'm explaining.
Okay.
Concordant care, folks who look like us, folks who know who we are, who know how to talk to us, who know when somebody say I gotta touch a sugar, what that means. Because folks who don't look like us don't understand that. So it's really important, and the statistic is very clear. If you don't have your little ones interested in math and science by the 3rd grade, they have surpassed being a health provider. It's not gonna happen for them. So early on, encourage them when they're doing the little Legos and thinking about math and all, just whether you know it or not, just make sure that they're encouraged to be there. We need a stronger workforce that looks like us, that cares for us. Yeah. 3rd grade, but if they have not gotten into math and science by the 3rd grade, they are already behind on the trajectory becoming a healthcare professional. And I don't just mean doctors, nurses, community health providers, all of those folks, we need them. The second, basic researchers and scientists, come on, sis, thank you, call it out, scientists who are doing the bench research to get us to this, thank you. Additionally, we haven't talked about public health either, and I think that's really important to talk about. Folks, we talked about health literacy, and people do not understand health literacy, and part of why folks aren't using their insurance, because they don't understand insurance. But also people don't understand public health. They don't understand that your water that you turn on the tap and can drink is safe, because there are public health folks who are testing your water and making sure it's safe, and putting in regulations on corporations to not dump things into your water that makes it unhealthy. They're the folks who are helping you get screened. A lot of folks are getting screenings for different diseases through public health providers. COVID required a responsible workforce on the public health side, working with a responsible workforce on the healthcare side. So get folks interested in public health, making sure that you're looking and understanding what public health is. Those are the two things I think we haven't said just yet.
That is an excellent point, and I want to dovetail off of that point a little bit, because although I appreciate everyone's applause and reaction when you heard my background as a nurse researcher, there's not enough of us in the industry. You know, we are isolated. I don't know, I have never met anyone else, a person of color who is a researcher at a contract research organization designing clinical trials. So I think a solution to that.
I wanted to say, me neither. And I look at probably 20 clinical trials businesses a year to invest in. I have never, we're gonna talk after this, because I haven't either. And I think that's incredible, because when you design it and you reflect what you can design, you're in a position to reflect what you can design. And that is along the point of what you all been saying about reflecting your
If we are in numbers.
a voting block.
Well, I would say in the industry together. I mean, there are other researchers, there are folks who work at places like Genentech, and there are scientists. I do consider myself a scientist. But we need solutions that actually help to propel that education in our communities, and we need to be the catalyst to that. We need to partner with HBCUs and community universities to make sure that we're recruiting people into STEM situations where we can, really build our own community of scientists and technologists and all the people who make healthcare turn, make the healthcare world turn. The other thing that I'll say is that tying this back to regulatory and funding and what we can do legislatively is that I find this to be a really interesting thing. The NIH only funds about 2% of Black research. 2% of their funding. The National Institute of Health, right? Only 2% goes to Black research. We have to change that. And the only way that we can change that is if we are the ones affecting the change in the legislation.
You both hit on something, and I hadn't gotten to the workforce piece yet, but I'm totally in line. So what I tell students, I talk to a lot of students. I tell students, when you want to go to medical school, everything you do in school matters. Sit with that for just a minute. Everything you do, math, science, English, everything matters. So when you but that's planting seeds very early in students. Everything is going to matter because it's cumulative. The student may not understand how English helps me in medical school. They don't. But you have to make sure they plant seeds. Everything they do matters. And that's medical school, dental school, whatever it is you choose to do. And so you're right, planting those seeds very early is quite important. So workforce is quite important to me when thinking about it from the Black physicians. You know, we represent almost 6% of physicians in this country, right? When you think about Black women physicians, we're almost 3% of the physicians in this country. And so it's very, very important to me thinking about how do we continue to diversify the workforce. And this is ever since the SCOTUS decision in summer of 2023. So while people I feel like waking up now, I've been acutely alert ever since then, knowing the outcomes, because we immediately saw applications drop. Hispanic, Indigenous, Black kid, all of them. It was immediate the next session. And so we're continuing to see that. And so this is going to take a collaborative effort, right, to make sure that we sustain our kids, because we know you talked about racially concordant, meaning somebody looks like me, talks like me. I don't care if it's in research, I don't care if it's clinical care, it all matters. And the other thing we haven't talked about is the environment and climate health, especially as it relates to cancer, especially as it relates to chronic disease. And that investment, what do these things look like now? So it is going to be more and more important that the collaborations take place between our organizations. And I would say the Hill is fine, but we got to get to the states. We have got to reinforce ourselves at the state level, right? Many of our organizations are at the state and national level. How do we begin to create these coalitions more locally? Because we've got to get hyper local. And it's speaking to the community-based organizations, and I'll close. And just because I work in one also, resources. They are already many times running these tight margins. And if you can, I know my entity and even some of the largers, we've been laying off people, right? So the sustainability. And so as we come together, as we lead together, really going back home to think about creating your connections here, to get back to creating those and helping support the economic engines to sustain these entities.
Love that. I want to do a time check. Ricky, how good are we on time? 10 minutes. So in this last 10 minutes, we have two options. I can either prompt the audience to see if you've been paying attention, or the audience can ask insightful questions. Save us from me having to be professorial up here. So hopefully, as we have questions, pass around the mic, maybe state who you are, where you're from, and your professional and familial capacity. Because I believe if you don't have a professional and familial capacity, just what your context is here. Because I believe your perspective, people know a little bit about kind of where you're coming from. They might get a little bit into your perspective as you provide your question or your point. So who's first?
Good morning. My name is Dr. Terry. We'll first thank this panel. Thank you, Ricky, because I've come to this tent multiple times while here over the past 2 weeks. This is great conversation. My name is Dr. Terry Moore. I'm a pharmacist. I'm also the Vice President and Chief Strategy and Inclusion Officer for the American Association of are super important. I'm also a very hopeful and result-oriented individual. So I want to share with you some work that I'm doing. Lavanya, let me thank Genentech, because I'm working on a project that is to help diversify clinical trials. I've already talked with Pearl. We're going to be talking some more, Ricky, to get involved in this. The project that I have is to show how pharmacists, and we know pharmacists in the community and the hospitals, and I will just share, a lot of people don't know that any of the medication that you get it in the hospital, whether you get it at the corner pharmacy or wherever, you cannot get that without a licensed pharmacist. And so it's a tremendous part of the healthcare workforce. But this project that I have, because pharmacists are so accessible, I'm testing a model to create what's called the Pharmacy Advancing Clinical Trials Network. We're partnering with community-based organizations and schools of pharmacy to help increase the awareness and knowledge and trust and understanding about clinical trials. Because people don't, until they have that awareness, that, being able to advocate for yourselves, being able to accept a trial, it has to start with a shift in mindset. And that's what this project is testing. And Genentech has been so gracious. I've gotten 3 years of funding from Genentech for that, from their Innovation About Fund. So thank you so much for that. So I just want you all to be aware of it, because we're going to be pilot testing it in a number of cities around the country: Washington, D.C., Maryland, New Orleans, Houston, and the list goes on. So we'll have things out on social media, and we'll be testing this over the next 4 to 6 months. And then we hope to be able to bring data and results that show, because that's where we can continue sustaining this. So just wanted to make you all aware that there are solutions. We're trying to make some progress to addressing a number of these very, very important health policy challenges that our community is being disenfranchised from. So thank you all.
Thank you, Dr. Moore. That's fantastic. And it strikes me as that being an example of the type of solution-oriented work that can occur in this persistent climate of disparity and inequity. So a light, not at the end of the tunnel, an ongoing light, sort of in the middle of this journey. Awesome to hear. One more round of applause, please. Well, I'm going to ask when you have, I got you, Doc. I'm going to ask that when you come up, or rather when you say your question, come up, because we're live streaming. So speak out to the audience if you could. I know it's a hassle, but it's just a few short steps. Come out. Give her a round of applause as she comes up. There you go. Right over here. Or actually right here is fine. And then just introduce yourself. Name and
Hi, my name is Kristen McKinney-Nash. I'm actually a retired elementary school principal. The reason why I'm here is that my sister passed away from breast cancer in 2017 at the I have three boys. But and I currently run a nonprofit in her honor. But my question to you guys is, you mentioned that sometimes our doctors don't even know of these trials that are going on, so it's hard for us to get in. How sure that we're not only included, but that the doctors we're visiting have this information.
So 2 things. If you acknowledge and let your doctor know, that's the first step, because sometimes the communication lapses. and acknowledging and educating people on clinical trials that they could be eligible for. Many times we'll refer you to one of our oncology centers or colleagues, because you also need to understand eligibility. So it's not just because I know about it, understand the eligibility, but usually if you just voice it to your physician, we can connect you to places and resources to get it. But the first thing is people don't sometimes tell us.
Yeah, I was just gonna say, locally finding organizations that maybe offer these services and that can push you towards some of these resources. And then from just the personal perspective, not taking no as an answer and going and making sure that you're doing your own research, you're going and getting a second or third opinion, you're going somewhere else that resource is available. But I think that that's probably the strongest piece of advice.
And just to dovetail off of that, you know, organizations like Touch, the Black Breast Cancer Alliance, you can get support through patient advocacy groups. Through my organization site, we can all help you find clinical trials and support you and walk you through.
We have a trial.
Come on. Lady, you are not exempt from the rules. Right here.
whenwetrial.org website. We have 4 websites, but whenwetrial.org, we will help you find a breast cancer trial. We have a 24/7 nurse navigation team. And they're on board to talk to anybody, anytime, anywhere, and help you find a trial. We've found many. We've now signed up 28,562 Black women into our trial. But it's not enough. You know, our trial participation needs to be commensurate with the burden of disease. And one of the things I want to show, but it's kind of blurry, is that we have an example of a Black breast cancer triple negative cell versus a white one. They look nothing alike. What does that say about the drug? And we think that's true for so many diseases. And if we don't participate in research, we're all going to die. We also have a really good friend, Dr. Keith Crawford. He will find anyone with prostate cancer a trial. So if you need us, call us. We'll help you find a trial, and you know, we'll help you do it. Oh, there. So the that one is the white one, and that one's the black one. So what does that say about the drugs we're taking? Right. So unless we participate, we're gonna die.
Excuse me. So thank you, Ricky, and just another round of applause, because again, we said we'd open up for questions, but I think we need to also open it up to create a space for solutions. And Dr. Moore, I believe your name was, the pharmacy initiative with Genentech, Ricky, and the support from Genentech, but also the support from the panelists, the support from the audience. This is the solution making. This is what solutions look like. And in order to really grow the solution, and this is where, you know, we spoke about investing. That word is literal, right? Some people call it donating, being philanthropic, but it's going to take real cold, hard cash, sweat equity, as well as real cold, hard cash to make these solutions continue to grow and to continue to facilitate their scale. And that's when we start providing solutions at scale, you might start to see some real movement of that dial. Let's have a couple more questions.
I have to give credit to Lavanya and Genentech because they have funded our When We Trial from day one. And also we are now working with them to basically recruit Black women for all of their breast cancer trials. Because first in the industry, we're not knocking down walls that haven't been built yet. And they have gone to the wall for us to figure out how to do this and let us recruit for trials. So they're awesome.
Another round of applause. And then maybe 2 more questions if we have them. Yeah, I got you. I just want to make sure that, yeah, come on. Yes, ma'am. There you go.
Hi, I'm Lakeitha Anderson with Eli Lilly and Company. And I'm here mainly because this is very important to me and my friends are doing this. And right? Friends are doing this and no. I want to make sure, because I hear clinical trials. I think it's very important that we push clinical trials. since I started my company 7 months ago. I'm new there. And I'm the person in the room or in the company that's screaming, we gotta make sure we educate our people, my people. Okay. We gotta talk to our family members.
Yeah.
Because that's our direct recipient of education, right? And encouraging our people to understand what clinical trials mean. It's not Tuskegee experiment. It's not Henrietta Lacks. Those are examples. But let them know that they need our DNA to make sure medicine works for us. You just gave an example of how this looks very different. And that means that the medicine needs to be very different, right? So I just want to say that, and thank you for having this. You know, I was like, I'm doing it. I think Tammy told me about it. I'm like, I'm coming. Hey, because my friends are here, my sorority sisters are here. I see, you know, and I want to make sure that we push this, not just breast cancer, which is very important, but other things, everything. You guys are doing a lot of LP little leg. Yes. We talked about that yesterday. Talk about that. Well, I haven't been authorized to talk about that. I want to make sure. I'm here in my personal capacity, but I'm also see that we're not here, and I want to make sure we're here. We being Eli Lilly, right? I know the things like that, and I'm also I'm on the Congressional Black Caucus board, and I'm on the board of the National Black Caucus State Legislative. Those are places where this needs to happen.
Yep. So
we're pushing education out there to make sure we are well educated, and that means it means our families. So continue to push clinical trials. Thank you. Thank you.
That's why we're here.
And Yolanda, from Dallas. Go Dallas. But anyway, just wanted to be up here to say thank you, ladies, for highlighting this very important issue, but it also touches on other issues that we need in our families.
Absolutely.
That's why we're doing it. That's why we're here on the.
Absolutely. Thank you.
Yeah, that's why we're here, because we want you to go home to your house, to your porch, to the pink well, to the beach, wherever you are, and talk about health. I'm good.
You know, one thing I wanted to just say, I know we had somebody else who had a question, but
Yeah.
one thing I just thought about when you were talking about education in your family, and you said something, Ricky, that made me remember this, because I learned this in the process of helping my aunt with breast cancer. Danielle, you were going to talk about your family and your family history. I had no idea until my aunt had breast cancer and we were going through it. Doc, help me out. Breast cancer, thyroid, and prostate travel together in your family. I got it wrong, didn't I?
No.
So breast and prostate
and
colon,
colon.
there's a relationship.
There's a relationship.
Call them cousins.
Right. And it was important for us because we were like, wait a minute, granddaddy had that, and so had that, but we never even thought about the risk that could be to the woman, right? Because those are men things.
Prostate, the man with prostate cancer, his daughter is going to have an increased risk for breast. And so that's why the family history, when y'all fill out your questionnaires and go to the doctor's office, I send my patients back home often to ask, because our families typically, things are private.
Yeah. We have a tool in our bag, if you get our bag, called Know Your Her Story. And you can sit down and kind of chronicle everything that's going on with your families. Also, I'd like to say that, genetic cancer, so coming from your genetic history, is only about 5 to 10% of cancer. But that's what the genetic testing was based on. White bodies, right? So I have 3 generations of breast cancer in my family. I have no genetic mutations. But there's a gene in Africa that we don't test for here that's causing triple negative breast cancer in Ghana. So the genetics is critical to know that. It's a critical tool, but your family history as a Black person is even more critical, because we may not have a gene that's discovered yet, but we know it's running in our families and we have to talk about it. It's also heart disease, and the Lp(a) thing is lipoprene A. It's a biomarker in your cholesterol, or a piece of cholesterol, to help me out, docs, in your cholesterol, that's causing heart disease in families, in Black families. And so there are a lot of clinical trials being done by Eli Lilly to understand that science. So if you have your father, your mother, your auntie, or whoever had a heart attack, that counts. That all counts.
As we gear up for this last question, we see you, sister. Just really, if you leave here today, know your family history.
Yeah, no, it.
I mean, go home and really talk to people. The
Yes,
issue,
today.
the issue is, right, for many of us, we may not know much, even my own family. There's very limited on certain sides. The other thing, there are so many women here today. I'll be remiss if I don't say it and I walk away. Oftentimes, women only think about their mother. You are half of your father. Understanding your aunts and your grandmother and your father's history are equally important. So often we always just think it's only what happened to our mother. I just had to say that point. The genetic piece is important. And the other piece is, even if you had genetic testing, the beautiful thing is that they keep the DNA. I just had a patient this week. We tested her in 2017. And we saw a mutation, but they'll call it of undetermined significance. But we keep those mutations because remember, we're still exploring the human genome. We are still, even though you may have a genetic mutation, sometimes we just don't know at the time if it's affiliated with cancer. So I get an amended report on here. 2017 is now 2025. And that amended report is now we know more about the gene she has. It's associated with pancreatic cancer, right? And breast cancer. And guess what? Her father died from pancreatic at age 47. So we're now able to get her the appropriate screening. So I believe in the genetic testing. Have that conversation we understand the barriers with payment, that kind of thing, but understand there are still things being revealed about the human genome.
Thank you guys. What's the time check? Just want to know we have two here.
We're gonna do one more question.
One more, even though we have two.
Okay, too quick.
This will be really, really quick.
No, Sam, we don't do two.
My name is Carrie Gober. I'm with the American Cancer Society. This has been certainly obviously representing myself here, but this has been a space personally for me for healing. I had no idea. I did not know. My mother passed away of breast cancer. My father from colon. So I did not know that thread. I'm currently in my own process of genetic testing and biomarker testing as well, both me and my brother. But I also wanted to just have one other comment because Dr. Lawson and Levant, you both were on a panel yesterday, and I know Micheline is not here, but I think it's important to also shout out the National Medical Fellowship. Oh, I'm sorry, Derek. I'm so sorry. But I wanted to make sure that in this forum too, that we know more about that and that we also are investing personally into that pipeline as well. And personally, I wanted to just highlight three people if they could just stand because they have been instrumental, not only to me personally, as my journey and just learning things within research. Dr. Tawana, I call her doctor, but she has been an amazing person in this space. And I wanted to acknowledge her. Dr. Lawson and Ricky Touch has been amazing. If you don't know these three ladies, get to know them. They are amazing and they have just helped not just me, but a community globally and locally in the space.
Thank you, Mary, for that.
Good afternoon. Oh, good morning. Hello. And that we was talking about grown folk business. Remember that's what we don't talk about grown folk. Okay, so my name is Tracy Williams. I am not in the medical field, but I'm in the mental health field. I'm a social worker. I am also what is this? I'm a friend of Pearl's. So I'm here to support her, and I am a 2-year breast cancer survivor. I had adulterous carcinoma, but I want to speak from the end user because I think a lot of times we hear high level stuff, but I'm an end user. Ask questions. We have to force our doctors. I saw 2 oncologists when I was getting ready to have chemo. One was a Black woman, one was a white woman. I asked the white oncologist about statistics. She didn't have statistics for Black women. She was able to give me statistics about age, the kind of cancer I had, ... I'm still waiting for the Black woman to call me back. because she never called me back, and I ended up on with the white oncologist. But I say this to say, ask questions. A lot of times we don't ask questions. We just think that the information that's given to us is golden. What the black oncologist did say to me was, this is what we use at Sloan Kettering. Well, I'm not a generic person, so you can't just tell me this is what we do over here, because that says to me, you do it for everyone. And there's nothing personal about the treatment that you want to give me. So that really deterred me from going with her. I'm glad I went the direction I went in. The other thing I will say is, as we move in these spaces, take someone with you. I was fortunate enough that two of my very best friends are doctors. So doctors speak, you all speak in doctor. So you speak in doctor, and it's a very different language for people who don't speak that language. And I was blessed and fortunate to have those people in my corner at the time. So I will say, I'm gonna say thank you from the end users, because we truly appreciate what you are doing for us. But also on the end user end, don't stop asking questions, because no one's gonna advocate for you better than you.
I just want to piggyback. You're right. It is very, very important to always take someone with you. When you are diagnosed with something, your stress level is super high. You may not even hear everything. It's oftentimes the husband will be like, she's told you already. She already answered that question. You're just trying to process all that's being given to you. The second thing is just speaking to you when the doctor said that's the Sloan Kettering way. So there are protocols, right? Those are protocols, but really the most useful information is not your age matters, right? When we deliver treatment, race isn't it. It's what that tumor, the histology, what those cells are telling us. We're running genetics even on that. So it really is, the question is really let them explain to you about your specific tumors, a lot of that. So typically, even when you have a cancer, I don't care if it's uterine, breast, lung, whatever, on most hospitals, we have what are called tumor boards. We sit and we meet about, based on your tumor, your histology, your cells, and the rest of you and your unique, what treatment protocols you should be entered. Cancer treatment typically is going to have protocols. So those, that may have been what they meant, but I hear you loud and clear. We often are meeting, yeah, that's that. So just know it's.
So my treatment plan, she brought it before a board to determine why that particular treatment that she used did not shrink my cancer cells, because it's according to the statistics that she had based on my cancer, it should have worked.
That's tumor response is what we're calling. How is it responding? And so, yes, that is customary. So just know you may just be interacting with the doctor, but know there are things behind and the teams that are looking at this, pathologists and others that are reviewing to figure out and determine what is the best treatment process or medication or protocol for you.
Thank you for sharing. Appreciate that. And thank you for the panel for sharing their perspectives and their wisdom. Thank you to Ricky and Touch, or the organization, my wife, for allowing me to host this panel. Give everybody a round of applause, because we're all compact. I'm gonna end by saying this. The solution is in this tent in various capacities and perspectives, and I would encourage us all to seek each other out so that we can continue to find the solution, because it's somewhere in you. Thank you.
Couple of things. Thank you again. One more round of applause for our amazing panelists and my delightful husband. Please scan our QR code. There you will find a place to donate. You can get a beautiful scarf if you're interested. But please take a bag. Please do our survey. That's very, very important for us to be able to be here. Yesterday, we heard that the revolution must be funded. So I want to thank all of our amazing sponsors, including AARP, Gilead, Exact Sciences, ASI, Daiichi Sankyo, Pfizer, Merck, Novartis, AstraZeneca, and of course, the amazing Genentech. They were our first funder, allowed us to be here this year. But I also know that the revolution must be felt. So I hope you guys feel at home here. I hope you feel that you learned something. So please share that in our survey. And thank you for coming, and feel free to ask questions as we close out today. Sign our roots poster over here so we can get to know where you're from, and make sure we can connect with you guys later. So thank you. And oh yes, and if you did not sign in, please make sure you do that. So again, we can record all of these numbers and share them with our funders. Thank you. Tomorrow we're having our last panel called the grand finale. So get excited for all the topics that we did not cover yet. So endometrial cancer caretaking tomorrow at 10 a.m. So we'll be right back here. Thank you.